We are going to start the first session. The topic of the first session is pilonidal sinus to be conservative or aggressive. I invite Dr. Lalit Aggarwal, Professor of Surgery from Lady Hardinge Medical College.
Well, good morning, everybody, and thank you, respected chairperson. At the outset, first of all, I would like to thank Dr. Pilonidal, Dr. Rajiv Singh, sir, for inviting me once again to the MAMC Update 2019. Well, the topic which is allotted to me this year is pilonidal sinus. And that is exactly what I was discussing with Dr. J.J. Singh right now, that we have a lot of patients of this entity in our day-to-day settings, but it is probably one of the least read topic by the postgraduates. One reason, probably they are not getting this as a clinical case, and not too many people are interested in this part of the surgery. So I thought I would like to take this opportunity so as to make you read about this pilonidal sinus and make you prepare for your postgraduate exam also. And at the same time, I would like to justify my topic, whether to be aggressive or conservative, once we come across a pilonidal sinus patient. Now, coming to the etiology, it was first described by M. Hoggs in 1880, on whose name actually the acquired theory right now is going on, that the hair induces a foreign body response in surrounding tissue leading to sinus formation. There are many other theories like preen gland, medullary canal vestige, traction dermoid, but once there are so many things, that means nothing is concrete, and we have to rely upon something which has got substantial evidence. It is 2.2 times more common in men and usually occurs in second and third decade of life, and it's rarely before 15 or after the age of 40. It is also called as Jeep disease, as we all know that the main etiology is because of the compression and the irritation of coccyx. So it is thought that during field activities such as driving in jeeps, and that is why it has been renamed as a Jeep disease. Coming to risk factors, it includes obesity, the hair growth, family history of pilonidal sinus is also one of the factors, local trauma and sedentary occupation. Most common in non-Hispanic population. Why I am telling you all this is, again, because it's again one of the neglected topics by you people for your exams. So at least you will listen today and learn something, if at all it comes on in your theory or wherever. Now we have two presentations. In OPD we see two types of patients. One is acute abscess and one is chronic abscess. And that is exactly where my talk starts, whether it is conservative or it is surgical. As far as chronic pilonidal sinus is concerned, if we sit in the OPD, we rarely talk of conservative method. But acute abscesses, so I went through the literature and find few techniques which we might apply for our patient for conservative methods. It presents in acute form as an abscess, or chronic form, as we all know, with single or multiple branching sinuses. So these abscesses ultimately present with sacrococcygeal pain with progression of fluctuant mass slightly off the midline. And that is approximately the finding in more than 50% of the patients who present acutely to us in the OPD, and more or less these patients ultimately become chronic if not properly treated in the OPD, on the OPD basis. So the acute patient also needs to be treated in a very diligent manner, and the treatment is slightly different the way we treat the acute abscesses. First of all, on examination, there is a presence of characteristic midline pits in the gluteal cleft, with pilonidal sinus is almost always visible, sometimes with hair or debris. So how to drain an abscess? That is very important, because if it is drained spontaneously, it is going to convert into a chronic pilonidal sinus, which requires treatment at some point of time in the patient's life. And these are non-healing because of the debris which they usually contain. So the primary aim is, one, that you have to remove the hair also. As I have said, that it is manifested by chronic draining sinuses in the intergluteal fold or the recurrent episode of infection. That is how the patient usually presents to us. And there are a lot many differential diagnoses which one has to consider before we label it as a pilonidal sinus, like Frankel disease, hidradenitis suppurativa, perianal abscess, sacral osteomyelitis, syphilis, tuberculosis, and actinomycosis. So these are all uncommon diagnoses, but one should be very careful that you have to do it. And very important that you have to do a thorough anorectal examination to evaluate for concomitant fistulous disease, Crohn's disease, or anorectal pathology. So do not ever try to forget doing a basic clinical examination of perrectal and proctoscopy in every case of pilonidal sinus. You might be surprised sometimes to find a concomitant pathology, and if left untreated, patient will keep on coming to you again and again. Now coming to the management. Simple incision and drainage, as we say for all the abscess, is the standard treatment to provide acute symptomatic relief. But in acute abscess formation, a stage approach should be employed, as definitive resection with abscess results in nearly 100% recurrence. This is because of the contamination of tissue, surrounding tissue edema, and midline sinus. So this leads to incomplete excision, and that is how this abscess is different from the usual other abscesses in the body, which heals once you give an incision to these abscesses. Now the drainage procedure can be done on the OPD basis under local anesthesia, not an issue, but this is the approach which is to be followed. Paramedian longitudinal incision is made over the abscess cavity that is large enough to allow for the adequate drainage. And the focus and emphasis should be on that all the debris and hair should be removed from the cavity. Even then, with good meticulous surgery, there is a very high chance of recurrence, but at least patient will be symptom free. Retained hair in the abscess cavity is the major factor for non-healing and recurrence. And the advice to the patient in the post-operative period is that sitz bath, weekly wound checks, and the surrounding skin should be free from hair. Some surgeons do advocate laser hair removal as a permanent therapy and to prevent the recurrence for the chronic sinus or the acute sinuses. And it has been shown in the literature that decreasing the hair growth in the involved area leads to better outcome in the surgical period. Now coming to the chronic lesions. Now this term I have added conservative. I know there is no role of conservative methods, but in literature there are few terms which are given with equivocal results. First is maintaining good personal hygiene by taking bath daily, an advice which we will give to everybody. Removal of hair in the perianal and natal cleft area at regular intervals is very important for the patients who do not undergo permanent hair removal. Oral broad spectrum antibiotics with anaerobic coverage. Whenever there is an acute or chronic setting, this should be given. Now, installation of liquid or crystalline phenol has been shown in some studies, but there is intense pain and it might require hospitalization. So, just to cover up the topic, I have included this as a list, otherwise not of much role. And there is a limited lateral incision and drainage of the abscesses. And one thing is very important, that one should always keep the affected area dry. So, these are the few of the conservative approaches which one should advocate as an adjunct to the surgical therapy, I will say. Do not offer this as a primary therapy to any patient. Now coming to surgical techniques. There are many surgical techniques which are mentioned for pilonidal sinus. And as I said earlier, when there are many techniques, nothing is foolproof. People are experimenting with one, not get enough results, got to second, third, fourth. So this is exactly what is the case with the pilonidal sinus also. People started with excision with skin grafting, got high recurrence, went on to Z-plasties, and then came the era of, there is one standard approach is that you give a wide local excision and leave the wound open. That's a one of the methods which we usually employ for pilonidal sinus, but not acceptable to most of the patients. So then came the era of flaps. This flap is very common, the Caridakis flap. The purpose of whole flap is to actually bear the tension of the midline and to recreate the natal cleft so as to prevent the recurrences. This flap consists of oblique elliptical excision of the diseased tissue with fixation of flap base to the sacral fascia, and the flap is closed by suturing the edge of midline. But there were recurrences. So people modified it And the only difference is that the closure is performed without taking the flap to the sacral fascia, aiming to prevent a formation of new vulnerable raphe by flattening the natal cleft. So everything is done off midline. Now Limburg flap, I hope you must have seen in your hospital settings, is a rhomboid flap with excellent results. Only thing is the prerequisite is that it should be abscess free, there should not be any discharging pus at that moment. A midline rhomboid incision to the presacral fascia, and you have to measure it and then you have to draw it, including the sinus is performed. Then the flap gains mobility by extending the excision laterally to the fascia of the gluteus maximus muscle. Now there is another modification is due foremental modification that permits the repair of the rhombus shaped flap with any combination of internal angles, because there is, in the previous slide, these are the internal angles which are formed in the rhomboid flap. So this modification takes care of that also, and that's a slight modification. Again, many things have been tried. People are happy with whatever results. They are in the best of the hand. What you practice, if you are happy with your one result, keep on performing that. Then is the VY gluteal advancement flap. Now Bascom cleft lip flap. This is usually used for cleft lips. You must have heard of it, but people have advocated it for recurrent pilonidal sinus. Because once there is a recurrence and once the already flap is being done, you have to do something, you have to offer something. So this is one of the option in the recurrent pilonidal sinus. This technique aims to reduce or eliminate lateral gluteal forces on the wounds by filling the gluteal cleft. The sinus tracts are excised and then the full thickness skin flap is extended across the cleft, midline cleft, and then it is closed off midline. Again, the results are very good after this, but recurrence is recurrence. We cannot say it is that you can provide the 100% disease-free to the patient. Now this is the Bascom flap. I have already told you that you excise the area and then cover that area of the midline with the full thickness skin flap. Now another approach is Leahy's and Kettle's relaxing incisions. I have just named it so that you should be knowing what are the options in the chronic pilonidal sinus wound management. So this relaxing incision is given on one side of the buttock to relieve the tension on the main wound sutures with the lateral closure of secondary wounds by sutures or advancement. Another flap to be mentioned is the rotation flap, in which there is a rotation into the defect and the secondary defect is closed at a later period. It's a staged procedure just to see whether the recurrence is there or not, and then you do it at a later stage. Now this is one of the commonest surgery which is being done is that after the excision of the entire sinus, wound is left open to granulate and heal by epithelialization with regular dressings. Only problem is that a lot of morbidity, not acceptable to most of the patients if you have not consulted the patient properly in the preoperative setting. Now another name is the Bue's marsupialization of sinus tract. What we do is that after making incision on the sinus tract, the edge of the laid opened area is sutured to the skin edge all around using skin or vicryl. This reduces the healing time and promotes healing. Another name is Lords and Millers, just to name the few. Now coming to the few things like injection of phenol. There are many papers on it, and people have shown good results. I have no experience, but people are showing that it maybe in the recurrences you can try it, but not as a primary modality in these treatment. The malignant degeneration is reported in only 0.1% of the cases. So that is why all the specimens, whichever we excise, has to go for histopathology. So don't consider it's a pilonidal sinus, we should just throw it out. No, everything has to go for histological examination. RFA has also been advocated. Lasers are emerging as a primary and adjuvant treatment option for pilonidal sinus, and that is what exactly the patient also demands, that Doctor Sahab, koi laser surgery hai aajkal? Is there anything we can do? Anything short of open surgery. So they are coming. One is hair removal, and then is even the pilonidal sinus also, they are being treated with the laser surgery. Results are still not very clear, but you can offer. So depilation with the lasers has demonstrated the most consistent evidence. The firm texture and quality of the hair is proposed to incite. So that is the one advantage, that the permanent loss of hair, and that is why the recurrences claim is less. Therefore, using a laser to permanently remove this factor may help and prevent the future disease, and literature supports it overwhelmingly. Now coming to my topic, be conservative or aggressive. I have gone through the literature and come out with the guidelines. And these are the recent guidelines which are being published so as to be very clear what to do. And this is published in 2019. These are the American Society of Colorectal Surgeons. They have developed a practice guidelines. And as we all say, the guidelines are guidelines, these on the basis of which only the decisions can be made. But here the patient and the day and the disease, you have to decide according to your own and probably the methods of treatment which are available to you. Now first is, in the absence of an abscess, a trial of gluteal cleft shaving may be used for both acute and chronic pilonidal sinus as a primary or adjunct treatment measure. Level 1C evidence. Level 1C up to 1A, 1B we accept it blindfoldedly. 1C and beyond we have to think patient by patient. So level is low quality evidence, but it is recommended. Patient with acute pilonidal sinus characterized by a presence of abscess should be treated with incision and drainage regardless of whether it is a primary or recurring episode. Level 1B, strong evidence. So every patient has to be treated with drainage to provide symptomatic relief. Patients who require surgery for chronic pilonidal disease may undergo excision and primary repair with consideration for off midline closure. Excision with healing by secondary intention or excision with marsupialization based on the surgeon. So drain use should be individualized. So surgery is the modality of treatment. There is a very high quality evidence which is available in the literature also. Now what procedure? The flap based procedures may be performed especially in the setting of complex and multiple recurrent chronic pilonidal sinus when other techniques have failed. This is the level of recommendation. As a primary adjunct, yes, you can offer it, but for the recurrent disease, flap is a better treatment. That is what the literature says. Then the operative strategies for the recurrent pilonidal sinus should distinguish between the presence of acute abscess and the chronic abscess and the chronic disease, taking into account the experience and the expertise of the surgeon. Now this is just a chart for a revision. Level 1A, 1B, 1C. It is the strong recommendation and moderate quality evidence. Once we talk of 2A and 2B, it is weak recommendation and high quality evidence based on the RCTs. So 1A and 1B is RCTs and rest are the observational, and 2A and 2B is also RCTs, but lot many limitations are there. So we accept blindfoldedly the 1A and 1B recommendations. Now this is a very interesting paper which is published in Nature in 2018. The meta-analysis, the merged data analysis and the comprehensive study on the recurrence of common surgical procedures for pilonidal sinus, it showed recurrence rate of less than 1% for the flap procedures, Karikadis, Bascom and Limburg's. So this is one of the good paper which was published, and the flap procedure has been recommended for even as a primary procedure for chronic pilonidal sinus, provided the patient is actively disease free. So pilonidal sinus is a chronic disease which predominantly occurs in young adults and can be a significant cause of morbidity. Since conservative methods do not actually eliminate the factor causing recurrence, surgical methods are best in treating the disease. The surgical approach for treatment should be the presentation of the disease, and the options should include, as I have told you, simple incision, deroofing, local excision or excision with so many procedures. Adjunct treatment in the form of hair removal is a necessity to help facilitate healing and to prevent recurrent disease. All efforts should be made to prevent a chronic non-healing wound which could be worse than the initial presentation, because it's a lifelong morbidity if not treated adequately and if treated inadequately by a surgeon. Off midline procedures have been shown to be statistically superior to the midline closure with regard to healing time, infection at the surgical site and the rate of recurrence. Tension free and off midline closure are the two principles to be kept in mind while dealing with the chronic pilonidal sinus. So ladies and gentlemen, to conclude my presentation, the message is all pilonidal sinuses should be treated surgically conservative methods should be adjunct, which technique is surgeon's preference, the area, the hospital preference, and the availability, and there is a very limited role of conservative management. Thank you.
Thank you, Dr. Lalit, for the nice presentation. Before we go for the question, I would just like to share my experience in the pilonidal sinus, that we at Safdarjung started doing this limber flap, and we had the excellent results. I found it very comfortable and very good procedure. And now for the last 3-4 months, we have been doing a laser in the pilonidal sinus. We have been using laser diode lasers, and we have done about 10 cases, and the results are excellent. But the period of study is still short.
Yeah, that is exactly what literature is also mentioning, that laser is coming up in a big way in a pilonidal sinus. Yeah. And we also have a very good result with the flap procedures for pilonidal sinus, provided it should be patient, has to be very nicely characterized for that.
Because I see the future is going to be the laser in pilonidal sinus. So any question from the floor?
Good morning, sir. So intraoperatively, what we can do to prevent the recurrence, like while doing cardiac flap or Limburg's flap, can we give, should we give drains or not?
Drains is surgeon specific. I mean, drain will not prevent the recurrence. Recurrence is if you follow the two principles of midline and hair removal, then you can prevent the recurrence. Drains will not prevent it. Drains is depending upon your surgical intraoperative findings, you can put or you do not put. We usually, or the literature also, do not support drain in the pilonidal sinus most of the time.
And so if we are putting, then when we should remove anything?
That is standard for all the drains. If you are happy after 24-48 hours, nothing is coming, you are happy there is no seroma inside, you can remove the drain.
Actually, the main cause of recurrence is when you don't excise all the tracts.
Branches
that is the
of the
major problem with the pilonidal sinus. If you completely excise and even off midline, then probably recurrence rate will be the lowest. So excision of all the tract is very essential. If that is what I feel personally.
Good morning, sir. What is the role of abscess in pilonidal sinus?
What is the role of?
Abscess, sir. Endoscopic pilonidal sinus treatment, sir.
I have no experience, but literature is that. That's what I said. Laser and endoscopic, because the limitation with the endoscopic anything is that it's a single branch. You cannot manipulate the endoscopy to multiple branches, and pilonidal sinus is a multiple branch disease. So that is why there is a very limited role, whatever is there. And the recurrence rate probably is more, because if it is not a single branch, then you cannot access the lateral branches with the endoscope.
We have used the endoscope for this pilonidal sinus before doing the laser in 2 or 3 cases. The only thing is that under vision you can take out the granulation tissue, unhealthy granulation tissue, or you can clear the track before start doing the laser. That's the advantage, but if the facilities are available, that's another option.
Good morning, sir. Sir, I want to ask that during open surgery, we have to just excise the whole of the tract or up to the pre-sacral fascia. How much we should go deep during excision of the tract?
Yeah, you are asking about open and leaving it open. Yeah, you have to go up to pre-sacral fascia, but main consideration is all the side branches and the tract should be excised and go right up to the pre-sacral fascia, and then let it heal from below up. Then that gives you the best result as far as open surgery is concerned.
Because if we go to up to the fascia, then it takes more time to heal.
Healing will take a lot of time if you leave the wound open, and once you have decided that you are going to leave it open, then don't worry about the healing time of 6 weeks. That you have to tell to the patient in the pre-operative setting itself.
Okay, sir. Thank you, sir.
If there is no question, thank you very much, Dr. Lalit, once again.
Thank you, sir.